like I mentioned, this webinar is titled Tobacco Interventions in the Dental Office. And here with us today are our two faculty presenters, Tanya Strickek, and joining us from her office is Dr. Deborah Saunders. Do you want to say hi, Debbie? Oh, Debbie, you may just want to press *1 to unmute your line. Perfect. Okay, so before we begin, again, I'm just going to go through some housekeeping slides. So remember that if you do want a letter of completion for this Teach Educational round, please make sure that you have registered for the webinar and completed the pre-learning assessment that's attached. Make sure that you are signed in to view this webinar using your first and last name so that I can track your participation. And finally, after the webinar, I'll be sending out a link to an evaluation and post-learning assessment, which you will have 1 week to complete. Okay. Now remember that these webinars are being live tweeted on Twitter, so you can follow the CAMH Nicotine Dependence Service at PS Quit Smoking, and you can also use the hashtag #TeachWebinar to post any questions or follow the live tweeting. So just to go through our faculty presenters, here is the bio for Dr. Debbie Saunders. She is a medical director of the Department of Dental Oncology, as well as the medical lead for the Tobacco Intervention Services at Health Sciences North. She's also a faculty with the TEACH project at CAMH. And these slides will be shared with you later, so if you want to see her full bio, you can always look through the slides after. Here are Dr. Saunders' disclosures. And here's the faculty bio for Tanya Strickek. Tanya is a registered dental hygienist working in private practice in Etobicoke. She's also a certified tobacco educator, and as well as a TEACH practice leader with the TEACH project at CAMH. And here are her disclosures, as well as our disclosures. Remember that the TEACH curriculum and slides were developed and compiled with funding from the Ministry of Health and Long-Term Care, and contents of slides are primarily based on evidence-based guidelines from the following sources. These materials, as well as the verbal presentation and any discussion, set out only general principles and do not replace the need for clinical or other advice as to any particular situation. So, like usual, before we begin, I'm just going to go through a few polling questions just to gauge who's joined us here today. Shirley says, can people hear me? It sounds like some people can't. If you can't hear, I would recommend just calling into the teleconference line. That might help. And I will try to speak louder into the phone. I'm sorry, I'm not sure why it's being that quiet. Okay, so. So using your computer, please indicate which region your organization serves. It looks like we have a lot from Toronto and the Greater Toronto area, as well as the Eastern area. And as well as your region isn't on here, you can always type into the chat box. So we have some Western Manitoba. Awesome. And again, please indicate which of the following you work for. If it's not listed on here, you can always type into the chat box. Looks like we have a lot of family health teams and hospitals, public health units. Wonderful. And finally, please indicate what your current discipline is. You may need to scroll down just to see all the options. And if it's not there, again, please type into the chat box. And it looks like the majority are registered nurses, some addiction counselors, health promoters. Perfect. Awesome. Okay, so with that, I will not delay any longer. I will leave it to you guys to take over. Thanks so much.
Thank you. I hope we're not having too much problem with the volume, but if anyone can't hear me, I'm speaking into the phone, and just let me know if you're having issues hearing my tone. I'm happy to be here co-presenting with one of my colleagues, Tanya. She's a dental hygienist. I'm a dentist. As anyone knows, in a dental practice, we work symbiotically together, and one cannot go without the other in my mind, especially when it comes to tobacco intervention. I'm going to talk a little bit about where I come from and really how I became a strong advocate of tobacco intervention in the dental community. I work in the world of cancer, oral cancer predominantly, and with oral cancer globally, it's actually the #1 cancer in developing countries, and the #1 cause of oral cancer is predominantly tobacco use. So working in a cancer center treating patients with this type of cancer and not advocating on tobacco intervention really seemed a little bit misleading for me, and for those reasons my staff and myself became true advocates for not only running the tobacco program in our cancer center, but really advocating and screening every patient that we see that comes through our clinic. So I'm really glad to be presenting with somebody who works in private practice as well, because there are definitely some teachable moments that we have as oral health care specialists that we can share with our multidisciplinary colleagues that can really be teachable moments for those patients that are contemplating tobacco intervention. When we look at what the Oral Health Organization says, I show this on almost every slide that I present with because no one can undermine the statements that the World Health Organization says, and that tobacco is one of the greatest emerging healthcare disasters in human history. When we look at all the hospitalization rates and cancer rates, cardiovascular disease, COPD, diseases related directly to tobacco use, you can see how much of an impact we can have as healthcare professionals on advocating on cessation for our patients, not just with respect to the specific disease that we're trying to manage and treat, but overall their whole morbidity and overall lifestyle and quality of life can be improved just by us advocating for them. So I think this lecture is dedicated to our patients. What motivates us? We have a lot of people signed in today. We have 65 participants, and I'm really glad to see that we're representing the province nicely, and that actually there are a number of us from different disciplines. So I'm happy to have you here in discussing the impact of tobacco on the oral cavity, because again, I can see that those can be teachable moments for you. But what motivates us to want to advocate for tobacco intervention for our patients? I work in a kind of a tertiary prevention setting where patients have already acquired a disease secondary to their tobacco use. And as a tertiary prevention, we can still advocate for cessation in improving their treatment outcomes with their chemotherapy, their radiation, and surgery. But some of you may work in more primary and secondary prevention settings where actually you see patients that haven't even acquired the medical comorbidities associated with tobacco. And we come from all walks of life, but predominantly what motivates us is that we want to make their quality of life and overall longevity better. So what is advocacy? When I say advocating for our patients and their tobacco intervention, really is getting this guy out of the room. It's advocating for the patients that we may see on a clinical basis, but also advocating for our patients with our colleagues in having them discuss tobacco intervention and promoting that. I like this cartoon because it says, sometimes even if I stand in the middle of the room, no one acknowledges me. And as healthcare professionals, we know that in the literature it's stated multiple times that the biggest impact of patients having a successful quit attempt is by having their physician or dentist, pharmacist, nurse, dental hygienist, or somebody who is seeing them regularly advocate and recommend and advise on the benefits of cessation. So we do have a profound impact just by what we say to patients in helping them with that journey. When we look at the smoking prevalence in Canada, it's about 15%. Where I'm sitting right now in Sudbury, Ontario, we have some of the highest smoking rates in Ontario and some of the higher smoking rates in Canada. It really does a little bit mirror the socioeconomic status of patients, the age of patients in a community. But when we look at the overall smoking trends in Canada, we've done pretty good. Since 1965 to 2013, smoking rates have decreased over by 30%. We're definitely doing much better than we were before. And tobacco use in females has still dropped sequentially, but in males has dropped more considerably. So we've done some good work there, but we still have a ways to go. We can't forget about the disease burden that some of you are seeing in other aspects of medicine. We know that it's the leading preventable cause of death in Canada. We know that 37,000 smoking attributable diseases are accounted for every year, and that 1 in 2 smokers will die prematurely from a smoking-related illness. So those statistics are pretty profound for us not to advocate for tobacco intervention in our patients. Patients with mental illness, and CAMH has a great specialty course on mental illness and how to directly deal with their specific circumstances. But we see a much higher rate of tobacco use in this population, and they tend to be a little bit more difficult to manage, require more follow-up, but definitely when we can help this population cessate it, it definitely has a huge impact on their overall survival. When we look at tobacco use as a risk factor for 6 of the 8 leading causes of death in the world, you can see that a lot of these are recognizable. The ones that aren't attributable to tobacco really aren't issues for us in the first world, that being HIV and AIDS and diarrheal diseases. But we see the cardiovascular, the respiratory effects, the cancer effects of tobacco. So nobody can really argue that discussing tobacco intervention in the healthcare setting in any aspect doesn't play a role. Pertaining more specifically to where I am, tobacco use in cancer is very high in smoking-related cancers, where patients continue to smoke throughout their treatments, even though the primary cause of their cancer is attributable to smoking. We see it in our head and neck population predominantly, that 23 to 35% of head and neck cancer patients are still smoking at the time of their diagnosis. And we know that smoking accounts for 30% of all cancer deaths and upwards of 87% of all lung cancer deaths. So of smokers who make unaided attempts to quit, 95%, upwards of 97% of those will relapse within a year. And that's why Tanya and I are here to talk with you today. We're here to talk to you today to educate you that cold turkey probably is not what we want to promote in our patients. We encourage those attempts with our patients, but we know that the relapse is really high. We know that relapse is common, but we also know in the literature that if we can play a role in advocating for our patients with follow-up and pharmacotherapy, relapse can be really minimized, because pharmacotherapy in conjunction with what we can offer as tobacco educators is really the best way to help our patients have lifelong cessation. So looking at tobacco and oral health, let's look at some of the things that we see in dentistry and see where we can provide those teachable moments across the spectrum of healthcare and not just make it so dental-centric. So every dentist and hygienist since probably year 2000, do complete head and neck examinations, checking for any palpable head and neck lymphadenopathy, any indurations in the mouth, or any oral side effects that may be specific to tobacco use. And we know as oral health care specialists that tobacco use is attributable to increased uncontrolled gum disease, more cavities because of the drying effects, decreased healthy microflora, which leads to more plaque, and of course cancer and precancerous changes. The Ontario Dental Association has created this fact sheet that you can actually download on youroralhealth.ca, yoh.ca. This is a republication from the American Academy of Oral Medicine, and I actually will educate this fact sheet to a lot of family practices, and they use it because really the mouth is a window to your overall health, and these oral lesions that are presenting in this fact sheet is very educational for the patient to see that tobacco is actually having a direct impact on their mouth health and how that relates to risk for cancer. So I encourage you to download and print this out for your patients, even though you may not be dental specialists. This is really meant for family practices and other practices abroad. When we look at the oral conditions specific in smokers, though, and zone into gum disease, which chronic periodontitis encompasses that definition, it's because tobacco use has a direct influence on the microflora in the mouth. It makes the mouth more acidic, less oxygenated, which allows resident microflora not to flourish as much as the microflora that can be attributed to more aggressive gum disease. We don't really appreciate that our first pass immune defense, our first pass immunoglobulins are actually found in the mouth, and tobacco smoke actually has a direct impact on this as well, which can have an impact on your gut microflora and your ability to fight infection. Tooth loss is directly attributable to uncontrolled gum disease, which tobacco use owns. And the impact on bone, which I'll go through further in the lecture. But dental caries is really related to the drying effects of the mouth from the tobacco smoke and the decrease in the healthy bacteria that are found commonly. So when we look at tobacco use and gum disease, and gum disease is a pretty important thing for us to manage because gum disease is the #1 cause of tooth loss worldwide. It's next to dental caries. Those are the two top bacterial infections worldwide, the plaque-causing bacteria that cause dental decay and the periodontal pathogens. So when we look at changes in the gums where you see that kind of a white patch next to that big molar on the side, what we're seeing there are the effects of, the noxious stimuli from the cigarette smoke. And what we're seeing here is the thickening of the gum tissue, which gives us an idea that there's some fibrosis going on. If you check that and you, as a hygienist, try to probe that, you tend not to see any bleeding here, and it's because of the vasoconstricted nature that nicotine causes, but also the fibrosis of the blood vessels in the periodontal pocket. That does not mean that there is no gum disease there. It just means that there's a more anaerobic type atmosphere, which the more pathogenic organisms like P. gingivalis and T. denticola can grow in that produce a more aggressive type of bacterial periodontal infection. When we look at the impact of smoking and implants and bone healing after dental extractions, implant failure is almost twofold more in patients who use tobacco. I actually don't place implants in patients that are smoking because the failure rate is just so high. So that, in conjunction with doing oral surgical procedures, surgery rates, infection, even across the board with heart disease, with cancer surgeries, is much higher in patients who use tobacco. When we look at smoking in older adults and the gum disease appears to worsen, we know there's a direct effect of uncontrolled diabetes with uncontrolled periodontitis. It's actually it's a direct effect on each other. And in patients with cardiovascular conditions, autoimmune conditions such as rheumatoid arthritis and obesity, and patients that smoke with these types of comorbidities can exacerbate their symptoms and make their conditions worse. But let's zone in on some cancer, some what we see every day in our clinical practice where we have a screening program for oral lesions. This type of white plaque that you see on the side of the tongue, the most common area for oral cancer to occur, is not cancer, but it's definitely showing me signs that the mouth is indicating some chronic long-term changes associated with tobacco smoke, and that this lesion may turn into a cancer one day and will require at this point lifelong surveillance. When we look at the spectrum of the development of cancer and where you saw that lesion on the tongue, that would be a hyperplasia where you're seeing that callus form. It's a watch and wait for that to turn into dysplasia and requires biopsy or regular evaluation to see if that lesion changes in consistently or color or size. And what we don't want is the invasive cancer, which requires a surgical resection and lifelong follow-up. So when we look at a lesion that looked very similar to that before, but now has developed kind of a focal ulceration, something that's not looking that great anymore, this is actually a tongue cancer. So this requires treatment, and treatment for these types of cancers, which are squamous cell carcinomas. These are one of the more aggressive cancers that you can get. They require wide margin resection, and overall survival in head and neck cancers is about 30%. So when we see an oral cancer like this is a diagnosis across the room. You don't need to be a dentist or an oral health care specialist to know that something's definitely very wrong here, and this patient requires immediate referral to a specialist for further evaluation and treatment. So the power of brief intervention and prevention on a primary, tertiary, or secondary level falls in our hands. A healthcare professional's advice to stop smoking increases a patient's rate of smoking cessation by 30%. Newer articles and research is showing now that is upwards of 66%. So we really can argue with the impact that we can have on asking our patients about their tobacco use and advising on the benefits of cessation. So the dental professional's role, we have a great opportunity to be able to see patients regularly. For all of you who go for your dental cleanings every 3, 6, 9, or 12 months, doing an oral evaluation and being able to advocate for patients' tobacco intervention, we get to see patients quite often. So tobacco intervention in the dental care setting has received a lot of attention more recently because we do have a great opportunity to see our patients easily on follow-up. So I want to go through 4 myths that I always find interesting that we can share with our patients, and you'll have a copy of this lecture after so you can revert back. Stop smoking medications are not effective in helping people quit. We know by a recent EAGLE study that was published in the Lancet in 2016 in April that tobacco intervention is almost perfectly effective if we can help and if we offer nicotine replacement and or pharmacotherapy for our patients. Myth 2, nicotine is the harmful substance in cigarettes. Nicotine to date has some studies to indicate it may promote tumor growth, but right now, by far, bar none, nicotine is not what's going to put us in a pine box. It's the noxious chemicals that are found in combustibles, in cigarette smoke. Combustibles can be anything from burned tea to burned grass, marijuana, cigarette smoke. Combustibles are bad for us overall, but more predominantly the chemicals that are found in cigarette smoke is definitely, a lot of carcinogens are present in those. Myth number 3, smoking is an adult choice and nicotine is not addictive. Nicotine is much more addictive than any substance that is available for people to use, more addictive than cocaine and heroin. We have to empathize with our patients, and whenever patients say, yeah, I have a bad habit, I always try and acknowledge and make them feel like, if this was a habit, you would have quit long ago. Nicotine is a very strong addiction, and we would never ask someone to stop using heroin or cocaine on their own. Nicotine requires, effectively, pharmacotherapy and counseling with people like ourselves listening today. So this receives a lot of media. There's always ongoing information about e-cigarettes and their effectiveness and their safety. I can definitely say right now there are 2 schools of thought in healthcare, those advocating on e-cigarettes because they are definitely safer than combustible tobacco, and then those worried about gateway access for our young individuals using e-cigarettes, getting addicted to the nicotine, and then turning to cigarettes because they may be more cost effective. So I definitely sit on the fence for that. I think we know enough to say that e-cigarettes are much more safe, but we cannot say that e-cigarettes are safer than what is tried, tested, and true, which is our pharmacotherapy and our marketed nicotine replacement. So why use medications? CanAdapt guidelines, CAMH, we all endorse the use of medications in conjunction with follow-up with people like ourselves to endorse and advocate for our patients for tobacco intervention. The role of medications can be psychological or placebo effect. It definitely has an impact. We've seen that with other medications and many other studies, and that's why randomized control trials always have to have a placebo. But we know that in the literature and in the science and what we see with our patients in clinical practice, pharmacotherapy and nicotine replacement with follow-up with people like ourselves can definitely have a better impact than asking our patients to do it on their own. So combining counseling and smoking cessation medication is more effective than either alone. Therefore, both should be provided for our patients or our clients to try stop smoking where feasible. So the effectiveness of medications, it's been studied. These may not be up-to-date references, but this is where this started coming out, that we should be recommending pharmacotherapy as a first-line agent for treating tobacco dependence. And despite this, many of us still just want to advocate and advise and then not offer help. So, you know, as a dental professional and a dentist who can prescribe pharmacotherapy, I love working with the dental hygienists in my team because they're all CAMH Teach trained. Some of them are certified tobacco educators like Tanya and myself, and we can really make a fruitful effort in the dental atmosphere for working as a team by having the patient screened at their new patient visit up front, and then know that we need to screen them and go through their tobacco use more when we work them up in the back clinic. So quitting smoking unaided, I've told you about this before. This is 100 minus 3 or 5, which equates to 95 or 97%, which I told you was a relapse rate for cold turkey. We definitely play a role in being able to help our patients if we add these lines of pharmacotherapy in advocating for our patients with tobacco intervention. And these all have pretty high stats for overall success. Varenicline is my favorite because I can prescribe it. I can follow up with the patient in 2 to 3 weeks or even 1 week. And if they need a nicotine replacement on top of that, we can work through that journey with our patients. But definitely nicotine replacement alone still has a very high success rate. And all of us can advocate on recommending nicotine replacement because that is offered over the counter. So even though you may not be able to prescribe, you can still advocate on pharmacotherapy and make recommendations where the patients can buy it over the counter. So in conclusion, we need to find what makes our patients tick. So what makes me tick is oral cancer and early detection, preventing and managing gum disease and decay, but that may not be what makes your patient tick. What may make her tick is her white teeth. She wants them whiter, or she wants less wrinkles on her face. So advocating for our patients is not always knowing what's important for us and what we think may benefit the patient, but asking the patient why they think quitting would benefit them and what they would like to see as an improvement. And it is true that smokers have 10 times more wrinkles than non-smokers. Advocating for our patients on the basis of that may be all that we need to get them going to see a response, even though they're in the dental chair with us. So I'm going to pass this over to Tanya to talk about better communication with our patients when advocating for tobacco intervention.
Thank you very much. I hope everybody can hear me. And I'm just going to get started. So what I'm here to talk to you today, I'm really here to talk to you about communicating your message. I'm going to talk to you about communicating your message in the dental office, providing brief interventions using the 5 A's and the 5 R's. Good, I'm glad that's better. There are so many resources out there for us to learn about tobacco interventions, clinical tobacco interventions. So my first slide here is really touching upon something provided by the BC Cancer Prevention Program, and it hosts tobaccoed.org. It's a great resource for those who want to support someone in a quit attempt, whether it is a clinician or a family member. And in looking into their clinical tobacco interventions, this website states that our healthcare system does not deliver clinical tobacco interventions systematically. We don't deliver it systematically across the board. We are not delivering interventions interprofessionally across disciplines. And as healthcare professionals, dental offices included, we really do have a duty. We have a role to play in improving these systems throughout all care. It further states that our patients, our clients, are really looking to us healthcare professionals to provide them with help in their tobacco cessation attempts. And as healthcare practitioners, wherever you practice, we do have an opportunity to provide very brief interventions for our clients, for our patients, to provide resources within a dental office. As clinicians in the dental field, we are in that head and neck area every day. We advocate for oral systemic health, and if nothing, tobacco is one of the huge killers of all health, whether it's below the neck or above the neck. In looking at the Canadian Task Force on Preventive Health Care, they do recommend that clinical tobacco interventions have A-level evidence as a preventive measure. And what is A-level evidence? It's stated here as good enough evidence to support that the recommendation be specifically considered in a periodic health examination. And this is published in the Red Brick, another great resource. It's a Canadian clinical guide to preventive health care, and it is a comprehensive clinician guide to interventions that you can include based on evidence. And I know Dr. Saunders has already touched on some statistics. I pulled these from the University of Waterloo. They did some research in 2015, so it is recently published that 68% of Canadians, that's two-thirds of smokers who have ever smoked, have now quit. We are down in purchasing our cigarettes. It's gone down from 42 billion in 2001, so we're still at about 29 billion cigarettes being purchased. And 13% of Canadians are current smokers, with 1 in 10 having purchased their cigarettes from a First Nations reserve within the last 6 months. And since 2015, the World Health Organization's Tobacco-Free Initiative has combined with their oral health program to collaborate and produce a monograph, the Tobacco Cessation and Oral Health Integration. And this is a downloadable resource which has lots of gems on how you can implement tobacco cessation counseling within specifically a dental field, but it really gives guides to all short interventions. It's a scientific foundation for implementing tobacco cessation into primary care. And it does guide us as oral health professionals with updated evidence showing that tobacco cessation is significantly, of course, associated with better oral health outcomes as measured by number of lost teeth, and as Dr. Saunders already mentioned, periodontal health, the risk of new lesions and malignancies. Certainly leads to a significant gain in clinical attachment levels of 2.5 millimeters. And it also states that all us oral health professionals, all professionals really, should be routinely offering 3 to 5 minute brief tobacco interventions to all tobacco users in primary care through both models of the 5 A's and the 5 R's. If anyone has read Motivational Interviewing by Miller and Rolnick, it is the hallmark of addictive behaviors, they state, that they persist despite overwhelming evidence to their destructiveness, as highlighted by Dr. Saunders when she was talking about some of the clients and patients that she sees who continue to smoke after their diagnosis. And it certainly is a conundrum for us if we admit it. Sometimes we do ask ourselves why people are doing what they're doing when it continues to be harmful for their health. And when we think about a dental office environment, or really any clinical environment where we have repeated contact with clients, we have an opportunity. As a hygienist, I have an opportunity when I see someone for repeated appointments treating their periodontal disease, with quadrant scaling or sextant debridement, to have numerous touch points to talk about their smoking and attempted quits. We do have evidence-based smoking cessation guidelines that are safe and effective and appear to be a very clinically meaningful intervention that we can offer as healthcare professionals. And in Canada, we have our CanAdapt guidelines that we can adapt to a dental office setting or other setting. We really have the ability and an onus on us as a client advocate to network with our clients and help provide them supports and measures beyond the office setting. Now, I have a little study here that is from Stats Canada Health Reports, and they have associated positive quit outcomes with one, being young, being a non-daily or a light smoker, and the light smoker is really 1 to 9 cigarettes a day, and receiving advice specifically from a healthcare professional, which was highlighted as a very important touch point for clients looking to quit smoking. And once again, as already highlighted in this webinar, but I can't stress it enough, even Miller and Rolnick note in their motivational interviewing book that 1 or 2 sessions of counseling can often yield much greater change in behavior than no counseling at all. So I'm briefly going to go through the 5 A's, which may be very familiar with some of you, the ask, advise, assess, assist, and arrange. And every time I say that, I tend to get that all muddled up. But I have created a little flow chart. And it really is quite simple. When you come across somebody who is new to your practice or even an existing patient in your practice, you want to update their smoking status or ask a new patient about their smoking. And that's going to guide you, depending on their answer, whether yes or no, where you go through those 5 A's. So if someone answers positively to the question about tobacco, you know that you can go through and advise and assess role, assessing whether or not they're ready to quit. And if they answer in a positive manner, you can move on to assisting and arranging, and however that fits for you. And if they say no and they're not ready that day, I will touch upon the 5 R's, and that can help you provide some motivation for your clients, for your patients, to keep that door open. And of course, you're going to get some people that do not have any use of tobacco. They've quit. They have never smoked. And asking about secondhand smoke to me is another touch point, especially when we see lots of young teens. We can discuss secondhand smoke exposure. They may be hanging out with their friends and they know nothing about the risks involved of being near secondhand smoke. And if they are abstinent, it's a wonderful time to encourage that for them. So when you're asking your clients in any setting, in a dental office setting, if they use tobacco, it's a perfect starting point to create a message. You want to ask with compassion and non-judgment and create rapport and partnership with that patient, but document their smoking status, whether they are a current, former, or never smoker or tobacco user, because there's other forms of tobacco, which I'm not really acknowledging, but there is. You can ask how much they may have smoked since their last visit, if this is a maintenance appointment. Having a new patient in your chair, you can ask how many years they've smoked and if they've attempted quitting before, and document this as a springboard for keeping the door open and keeping the discussion rolling. Really, having a system in your clinical practice increases the chance of success of any interventions that you may find applicable to your practice. And when you move on to advising your client, your patient, to quit smoking, you want to make sure that it's clear, it's strong, personalized, and definitely positive, using language like, Mrs. Jones, I see some changes in your tissues, and specifically whether you've identified a white patch like Dr. Saunders has shown, or Mrs. Jones has even said that she has a dry mouth. You can use that as a springboard for discussion, telling her that you take her oral health very seriously within your practice. You'd like to discuss her tobacco use further, and you do advise her that quitting smoking would be very good for her health. And here you can assess Mrs. Jones' readiness in relation to quitting. You could ask her how she would feel about being a non-smoker, or specifically asking, would you be ready to discuss a quit attempt? And Mrs. Jones' answer will certainly guide you again as to your next steps. It's also going to reveal how important quitting is to that patient that day, how they feel. Are they even motivated to quit? Do they feel they can even do it? How confident are they? And when you move on to assisting, it doesn't have to be overwhelming to you, the clinician. There's many small touch points you can do, starting with something like the STAR method, and just informing them that some planning around their quit attempt can be very helpful and increase their chances for success. They can set a quit date. They may engage their family and friends by telling their coworkers, and asking for support that way. They may anticipate some upcoming challenges to quitting, and there you can strategize around those roadblocks, and even suggesting they remove products from their environment, stuff out of the car, stuff out of the home, the tobacco out of the home before they even attempt to quit. Gives them a good framework to get started. And this can be easily done as a handout or a PDF that you can send to your patients. Assisting can also come with supplementary material or resources that you give to your clients. I've used Health Canada's resources, and I find people very, very receptive, even teens. There's some strategically sent and specific for your younger clients. Practical counseling, helping identify danger or really trigger situations for that person, whether it's socially or going out, and even providing basic information on planning about smoking and quitting. You can have a list of services that you can guide your client to within your community or province and encourage them through the quit attempt, which is easier as a dental hygienist because we are seeing repeat visits for someone who's having periodontal therapy and even 2-month maintenance appointments. You always want to be caring and show your concern and be empathetic, and suggest, too, that they may find someone to talk to about the quit process, maybe a group or even a quit buddy. That can be very helpful and very supportive for your client. Definitely arranging some outside support from the family doctor or pharmacist or a cessation specialist, and yes, talking about pharmacotherapy and replacement therapy is something that we can do and should do as dental professionals. We want to also have other resources available, like a smoker's helpline intake form. This can be faxed through other people in the office, your admin staff, and they will contact your client, taking the onus off the client for having to do the work themselves. And also, once they walk out of your room, it might not become a priority or be a priority anymore. Setting up a follow-up time or a point of contact at a later date, if that's feasible for you. A 5-minute phone call may be encouraging to that client. And even a suggestion of how will they reward themselves for making a positive and important decision in their life. This can be the impetus to switching behavior. And although we are talking, of course, of an addiction, sometimes losing that action of picking up a cigarette can be replaced with something more positive and make that person feel good. I have touched upon a study here from the British Dental Journal, and it looked at determinants of advice within a dental practice and really the attitudes, social support, self-efficacy, and knowledge within certain dental practices, how they felt about delivering tobacco cessation within the role of the whole team. And they did look at attitudes, with 3 being very specific, looking at fear, fear really being related to us not wanting to bother our patients and not wanting to alienate them or have them feel judged. Being uncertain as to your knowledge in providing these counseling skills. There are people who really don't feel comfortable providing knowledge or providing counseling skills. And there is some doubt really to how feasible it is to provide this within your clinical practice, whether or not they could follow through and carry that out. And other factors we looked at in this study was social support. Did dental offices really receive support from, specifically even with other team members, but insurance companies to offer reimbursement, and colleagues who were also on the same page, as well as associations and even local component societies? Are they offering education to dental professionals to support them in increasing their interventions? And the results of this study did show some significant differences in team members, but logically so. A dental hygienist and a dentist are really in a treatment role, and they are able to deliver interventions much more specific when they're with that client. But auxiliaries and others in the dental office can really play an important role in facilitating, connecting with resources, faxing that smoker's helpline form, and following up as well. Self-efficacy is heightened when everybody is supported within the dental team, and education is part of that team support, and that relates to increasing the knowledge in the dental practice. And the study did conclude that a team support or the deliverability of interventions within the team is really heightened when everybody is on the same page and there is a lot of team support. So I'm just going to briefly touch on the 5 R's, which is a motivational tool to be able to deliver some confidence building within your client. And it's used for those people that may not be ready to address their tobacco use at this time. And it may not be something you want to adopt within your practice. You can really use these 5 R's as a touch point and pick one, whether it's relevance, risk, reward, roadblock, or repetition. And when we look at the 5 R's, you can look to develop relevance with your client, with your patient. How is quitting personally relevant to that person? You may identify some negative consequences for them, and this can be developed if the patient specifically is giving you some insight. I have had a gentleman ask about secondhand smoke because he did have a grandson, and his own son did not want him around his grandchild. due to secondhand smoke, and he asked for more education around that. It was a great teachable moment. Rewards, even writing a pro and con list, the potential benefits of quitting, being able to make a decisional balance list, gives your client, your patient, a visual to look at really some of the positives that may come from them quitting smoking. Roadblocks can definitely come up. You can help identify any barriers or impediments to quitting. Fear of failure, if someone has tried to quit many, many times, or they feel they don't have support, especially if they have a spouse who is a tobacco user. They may be around peers who smoke. Women, of course, are always worried about weight gain. These are all things we can just give a quick 1 or 2 minute strategy session around. And repetition. Repetition of assessment of readiness is important. Perhaps today your client isn't ready, but you can certainly repeat the questions with permission at a later date by asking Mrs. Jones, if you mind, Mrs. Jones, if I discuss this at your next visit. You've left that door open and she knows that you're not judgmental and you're ready to talk to her. You're not ready, client. You can advise and assist and respect their decision and ask permission, as I mentioned, to discuss the next time. Leave the door open so they have a resource and a supportive system within you. And think about raising any confidence or readiness with the 5 R's that we have just discussed. I'm quickly going to touch on education versus support because there's some varied opinions as to what is really effective counseling. The International Dental Journal has published an article on the education of tobacco use, highlighting that education and support look very, very different. And really an intervention is more than just education. We don't want to just give facts, we want to give support. And education is very well meant, and when we all work in a busy clinical environment, it's very easy to fall back into that role of telling a client or a patient what to do, and that isn't always helpful. It may work for some, but they really do need a little more partnership, a little more collaboration, and unfortunately the education aspect in some can increase some pushback. Some actionable tools are really, really helpful. And I don't want to leave here without touching upon the barriers. I do recognize that there are barriers within certain clinical practices in implementing clinical tobacco interventions. Tobacco counseling can take time, but we do have evidence to support 1 to 3 minutes of touching on that addiction with your client. There are reimbursement concerns for some offices. We will encounter people who do not want to talk about it. They are ambivalent and they, in no uncertain terms, want to speak about their addiction and their tobacco use, and some clinicians do feel that they lack the knowledge to go further with their client. And it may not be feasible for your clinical environment, lack of knowledge or confidence, and there's lots of areas that you can upscale your knowledge. I'd be happy to share what I've learned with others later on if you'd like to contact me directly. And before I go, I just would like you to consider, again, I know Dr. Saunders touched upon a statistic of a brief intervention and what they can do for abstinence or quitting, but a brief intervention between 1 and 3 minutes can increase a 6-month abstinence rate by 14%. The overwhelming majority of smokers do begin to smoke as teens or preteens, and this can even speak to when you ask your patients, your new patients, about their smoking. Your office may provide a guideline. Will it be 12? Will it be 14? Will it be 18? Whatever is comfortable for you. And that intervention may just save a life or a lifetime of struggle. I really feel passionate about this topic. That is my mom, and watching her end of life in a horrific manner due to her tobacco use has made this topic extremely passionate for me. So I want to thank you. I do have further learning that you can take a look at when you get the slides. So I want to thank you for your time today.
That was great, Tanya. Does anybody have any questions? If you want to type them in, I was addressing some of the questions while Tanya was giving her talk on e-cigarettes and the vasoconstrictive effects of nicotine. No matter which mode you get, less vasoconstriction by using it as a non-combustible. But if you have any questions, we're here for you. I like what Tanya said at the end, and I did type in a line, you know, we're all advocates of tobacco intervention. We're all here for a reason at this webinar, but I liked what Dr. Bill Evans, who's a medical oncologist and an advocate for oncology in Canada, definitely for tobacco intervention. And one thing that he said really stuck well with me is that we don't need to, ask our colleagues to be tobacco education specialists. What Tanya and I were talking about today is just simple asking and advising our patients. And if we don't feel, or if our colleagues don't feel comfortable about the next step, just kind of endorsing with them, giving them the tools to refer onwards to those that feel more equipped to do it. Smokers Helpline in conjunction with a healthcare professional like a dentist, pharmacist, or physician who can prescribe pharmacotherapy, bar none, is going to have a bigger impact than us just leaving it, kind of still at the end of the advising. So I think for the dental community, we have a long ways to go. My team here in Sudbury and Tanya, definitely we see that there are some voids in our profession that we can only keep working on. So thank you.
I see there's a question from Haley. If a patient is not interested in quitting, how do you move on with the appointment? Really acknowledge where they're at and let them know that you understand it's a very complicated topic and that you're always here if they need to reach back to you for support. That's really what I do. You can't make choices for them, but you can be a partner and you can be there whenever they do become ready. I hope that helps.
So we do have time for a few more questions. Thank you both, by the way. That was incredible. We do have time for a few more questions before it's 1. So keep them coming in the chat, and Tanya and Debbie will do their best to answer those.
I like the question that Haley Northcott asked, and we definitely even find that in a practice setting like where I work in a hospital, where the hygienist will recommend tobacco intervention, ask and advise. They say they're not interested, and then I come in and I do the recall, and I'm just like, I'm noticing a lot of uncontrolled gum disease. You have a past history of cancer, and I can only advocate and advise on the benefits of tobacco intervention for you. And can we discuss that today? And sometimes, the conversation switches where they may be interested, and unfortunately, that can be the case, and we find that in medicine and dentistry, where the nurse can talk ad nauseum on the benefits of intervention. The doctor comes in and says, Joe, I really need you to consider quitting smoking because your health is not stable, and they're on board. So I think part of that is all working as a team, the groundbreaking discussion, and then the reinforcement by all of the healthcare professionals working in that team. That repetition is key. So that's why I really have to firmly endorse that my colleague dentists are endorsing tobacco intervention as much as the dental hygienists are, and I do see an imbalance in that right now. So we are working on that.
Just to touch on Jen's point, so I will be sending out the presentation slides this afternoon, and they will also be posted on our Teach website along with a recording of this webinar. So you can feel free to share that with your colleagues, or if you're interested in watching again, that'll be there for you. Does anyone else have any other questions before we wrap up for today? Some people typing, so we will give it a little bit. How's the weather in Sudbury?
It was wind chill minus 25 this morning. It's miserable. I need this winter to be over with.
But it's just spring.
Not first day of spring.
No, not so much. Okay, so it looks like we're getting a lot of thank yous, so I don't think there's any other questions. Reminder that you can always email teach@CAMH or Dr. Saunders and Tanya if you do have questions later on. I'm just going to go through a quick wrap-up just before you guys leave. So like Tanya mentioned, here are some future learning websites that you can go to and client resources. References. So remember, once again, that if you are interested in receiving a letter of completion for this presentation or for this webinar, I will be sending out a link to the post-learning assessment this afternoon. Sorry, link to the post-learning assessment will be sent out this afternoon, as well as the evaluation, and you'll have 1 week to complete that. If you did participate as a group, please make sure that you email teach@camh.ca with a list of participants before 2 p.m. today so that I can send you that link. So this was actually the last Teach educational rounds for this fiscal year. We are currently working on a schedule for next year, so stay tuned for that, and it'll be on our website soon. And again, if you missed the beginning of today's presentation, you want to view it again, share it with colleagues, or you're interested in seeing previous Teach webinars, no problem. You can view all of our archived webinars on our Teach website. And with that, thank you, and have a great rest of your day. Bye.
Thank you.
And thank you so much, Debbie and Tanya.
Thanks.